point to give a proper prescription to these patients. So first speaker will be Dr. Sudha from Kasturba Medical College, Manipal, who will speak on objective refraction. Over to you, Dr. Sudha.
Shall I start with big thanks to Dahlia and the KSOS for inviting me here. I get to see all my friends again. So why is objective refraction important? It's because if you do subjective refraction without some mode of objective refraction, it's like looking for a needle in the haystack. It's like a blind procedure. So the techniques available are either retinoscopy or autorefractometry. With the increasing use of autorefractometer, is retinoscopy becoming a dying art? I think so. So why should you know retinoscopy? Because it is important when subjective refraction is not possible. In infants and children and uncooperative adults. Also in the OT, you have a child under anesthesia, you have to know retinoscopy. Of course, Quitala. Okay, sorry. And if you have handheld autorefractometers, good. Otherwise, you have to know retinoscopy. It's also a screening tool for keratoconus and other media opacities. But the most important thing is that you need to know retinoscopy the day the AR machine conks off and your optometrist also skips work. Cycloplegic retinoscopy, what are the indications for infants and children? Because they have a maximal accommodation, the amplitude of accommodation. Children with ESO deviations, you have to bring out the total hypermetropia. In young adults with significant asthenopia, when your subjective and objective refraction do not tally. Also, when you're doing dry retinoscopy, you see there is fluctuating accommodation. That is, initially you see that it's a with movement, and then you see there's an against movement. You know the patient is accommodating. Then you need to do a cycloplegic retinoscopy. In all other instances, you have to do a dry retinoscopy. So I'm not going into the theory part. Basically, it is based on Foucault's principle. That is, you're trying to find out the far point of the eye. So if the patient is emmetropic, the emerging rays, so you're basically illuminating the eye, the subject's eye, and you have rays emanating from the eye. And if the eye is emmetropic, the emerging rays are parallel. If myopic, the rays will converge, and if hypermetropic, the rays are divergent. So you're trying to sit at the patient's far point. So if the examiner is at the patient's far point, all light leaving the eye will enter the peephole of your retinoscope, and illumination is uniform. So basically, neutralization is bringing the far point at the peephole of your retinoscope. So what are the advantages of the streak retinoscope? That is what we all use now. It is self-illuminated, it's easily manipulated. You can control the intensity and the type of the beam. You can, the axis of the cylinder, you can easily estimate because you can tilt the retinoscope. High refractive errors, we have a concave mirror effect. I'll speak to you about it. So basically you have two settings. You have a plane mirror setting and a concave mirror setting. So with the Welschalin model, when you pull the sleeve down, you have the plane mirror setting. So that is commonly used. Very rarely you need to use the concave mirror settings. That is when the sleeve is up. So it's usually used only if you want to, sharpen, you want to find the axis of the cylinder and you want to sharpen the reflex. So with a plane mirror, you get a broader reflex. With a concave mirror, you get like a thin streak. So it helps to find the axis of the cylinder. In high refractive errors, there's a thing that's called pseudo-neutralization. I'll explain that later. So a few tips for the procedure of retinoscopy. Do not sit directly in front of the patient because then the patient is going to look at you and accommodate. So you sit in front of the patient, but let the patient look behind you behind you at some distant target like Snellen's chart. So if you're doing the retinoscopy of the patient's right eye, use your right eye and your right hand. And for the left eye, you just move slightly to the right and use your left eye and the left hand. Always concentrate on the central reflexes. Ignore the peripheral confusing reflexes, especially in a dilated pupil, because you will see a lot of peripheral reflexes. So you know about the working distance and the working lens, 1 meter or 2/3 of a meter. You have to do correction for that. And some people also use a working lens. That is, you put a plus 1.5 diopter sphere on your trial frame and then you do retinoscopy. So it is for people who are a bit mathematically challenged. You don't have to do any arithmetic in the end. Whatever value you get, that is the power. Yeah, so it can also be used during dry retinoscopy to relax accommodation in the other eye. But when you have lot of lenses on the trial frame, it can cause some distracting reflexes. I don't personally use the working lens, but a lot of optometrists who use it. So how do you decide what lens to start with? Okay, that is based on the reflex characteristics. So when you do a retinoscopy, if you see the speed of the retinoscope, of the reflex, sorry, it's slow. That means it's well away from neutralization. So there's no point in starting with 0.5, 1 and all that. So you put a higher power and then you start refraction and you keep increasing with 1 diopter. If you feel the brightness, that is it's dull, that also tells you you're well away from neutralization, start with higher powers. If the width is narrow, it is far from neutralization. So as you reach neutralization, it becomes more a broader reflex, and at neutralization, it seems to fill the whole of the pupil. Also, the reflex regularity, it may be irregular in media opacities. So you know this, how do you find neutralization? You, if it is an against movement, you put minus lenses. If it's a plus movement, with movement, you put plus lenses. Some people also feel it's easier to work with a with movement. So what they do, if you see an against movement, they put a higher minus lens so that it becomes a with movement, and then they keep reducing the power. That is also possible, you can do it. How do you confirm neutralization? So once it's neutralized, how do you confirm that? So supposing you're having a with movement, you're adding plus lenses. Now you feel it is neutralized, you want to confirm it, you put a higher plus lens. Now it will become an against movement. So that helps to confirm neutralization. Also, you can move back and forth. That is, from neutralization, if you move forwards, you'll get a with movement. If you move back, it will give you an against movement. Now, pseudo-neutralization is described in some books. You can do this, like in higher myopic errors. So you see it is a dull, motionless illumination of the whole pupil. So what you do is use the concave mirror. That is, you put the sleeve up, so you have a concave mirror effect, and now you'll see a with reflex. But this with reflex has to be neutralized with minus lenses. So you keep putting minus lenses until you reach neutrality, and then you pull the sleeve down so that you get a minus. You get the plane mirror and an against reflex, and then you keep adding minus reflexes to reach neutrality. So in astigmatism, always measure the power, and then, before measuring the power, determine the axis of the meridian. So if you see there is a break in alignment between the retinoscopy reflex and the pupillary or the retinal reflex, that means you have to, your axis is not correct, you have to rotate the streak until this break disappears. Also, you look at the width and the intensity of the reflex. So if you see it's a thick reflex, that means you're off axis. So you have to move your retinoscope, you tilt it so that, move the reflex so that it is on axis and it's narrower. So a reflex beam which is thinner and brighter tells you it is better aligned. Also skewing. Skewing is when the streak reflex moves in a different direction from the pupillary reflex. Okay, so then that means you know it is not moving in the same direction. Then you align the axis of the retinoscope. Also in this you can use the concave mirror. Once you have got the axis, you raise the sleeve, narrow the streak so that you can find out exactly, like it comes like a line, so you can find the axis of the retina or axis beta of the cylinder. Straddling is also a bit theoretical, I think, but you can do this for confirmation of the axis with you put the correct cylinder in place, that is the axis. You think it is at 80 degrees. What you do is you move the axis of the retinoscope 45 degrees this side and 45 degrees this side. So whichever side it is narrower, that is the side towards which the axis is. So you can again move it towards that side and then again straddle on both these sides. So how do you find the power? So once you've got the axis, now you have to find the power. So you use it with two spheres. That is the easiest. With a sphere and a cylinder or two cylinders are all possible, but the easiest is with two spheres. Also a commonly asked question from the PGs is, how do you find the axis? So remember, if it is the direction of movement of the retinoscope. If you're moving it horizontally, so it is a vertical beam, but you're moving it horizontally. So you're moving this side. So it is 180 that you're looking at. If you're moving the retinoscope vertically, it is the axis 90 degrees. So if you're moving it like this, that means this is the axis and it's 45 degrees. And there you have to write the neutralizing power. Okay. So that's how you draw the retinoscope reflex. So difficult situations are in the presence of media opacities, high errors. So always look out, see if the patient has got his spectacles. That's the best clue that you can get. Otherwise, if you feel it's a high error, you try a +5 or a -5 lens and see, then you'll get a better reflex. In keratoconus, you get a scissoring reflex, but that is because some part of it is hypermetropic and the other is myopic, so you get that conflicting shadows. In gross squint, always you occlude one eye so that the deviating eye takes a fixation or looks straight, and then you can do the retinoscopy. Now, autorefractometry advantages are it's quick and simple. Anybody can do this, and no pupil dilation is needed. You can get a ready-made printout of the prescription. You can get a keratometry values and the IPD. But disadvantages it have accommodate. Patient can accommodate, and you can get an instrumental myopia, causing an overestimation of myopia or underestimation of hypermetropia. Also, near vision evaluation is not possible. Also, in the presence of hazy media, pterygia and keratoconus, it can be a problem. So control of accommodations, what we all use now are the closed loop autorefractometers, where a fogging mechanism is used to avoid accommodation, but this may not be adequately neutralized. So you have open field autorefractometers that are coming up, which eliminates accommodation, and this allows a binocular field of view through a window. So the patient is actually looking at a distant target. So this is just a picture to show you that where you have a wide view window that avoids instrumental myopia, and it also you have a near vision reading segment. So you get a near vision values also. So to end, you need to know some type of objective refraction. Machines cannot be depended upon. So basically, I think you have to know retinoscopy, and your personal knowledge and skill will be there with you all throughout your life. But however, retinoscopy comes only with practice, and you have to give some time to learn the art of retinoscopy. Thank you so much.